about transplants. Alfonso, thank you so much. For those who don't know Alfonso, who's way out on the West Coast right now in Vancouver, he is an underachieving cornea specialist. He has only done 3 years of fellowship training, spread over Toronto and Moorfield in England. And not only did he think that was not enough, he also did a PhD in immunology. Yeah? And so that was kind of some involvement in Rome, where he did his residency training, as well as at Bascom Palmer in Miami. So yes, definitely an quote-unquote underachieving person we have talking to us today. So we're actually quite lucky to have you, Alfonso. Thank you so much. Alfonso has been has joined us in the cornea community fairly recently overall, if you look at the grand scheme of things, but has really injected some real good clinical and research excitement into the Canadian cornea scene. And has been involved quite a bit with research, has been involved with fellowship and residency, involved residency training as well. So kind of covers all facets. And so today he's going to be talking to us about DALK versus PKP. And he'll tell you a bit more why the ultimate in-house showdown has been crossed out. So Alfonso, thank you so much again for agreeing to talk to us about transplants, and let you do your thing.
Perfect. Thank you, Kasha, for the kind introduction, and thank you to Precision Cornea Center to allowing me to participate to their rounds. Now, yeah, so I'll start by saying that at first I intended to do this presentation as a point-counterpoint with my better half, but unfortunately, because of a small medical emergency of our son, she couldn't be with us today. So you're gonna have to wait for another occasion to see us sort of bottle up in the ophthalmology field. Let me see. Okay, so these are, so we're gonna talk about DALK versus PKP and sort of go through the techniques and pearls and pitfalls in a way, and then look a little bit into the literature. So these are my financial disclosures. I am one of the co-owners and co-inventors of an instrument called iCode, which will be discussed during the presentation, which is not yet commercially available. And the other disclosure that I have to make is that DALK is my favorite kind of surgery. We all have one. We all have the thing that puts a smile on our face, and we're always happy and enthusiastic when we do that. And DALK is definitely the one for me. So first, I'm going to start presenting sort of a couple of cases that could come into any of us waiting room, just to put a little bit of clinical context to what's going to be said in the following slides. So 26-year-old male with keratoconus, can see well with his glasses. He can wear contact lenses. Anywhere is in Richmond. He lives in Richmond, BC, which is about 20 minutes drive from our hospital. The other case is a 70-year-old female. She's got bilateral partial thickness scars following trachoma. She's had cataract surgery with a suboptimal visual recovery, but she lives far away. She's not independent. She can travel independently. She lives in Prince George, which is about 6 hours away from Vancouver. So what kind of surgery would we think we could offer to these patients? Would we offer a DALK? How important is it for these patients to get a DALK when they have cornea transplant? Put this in the back of your mind for the moment. We'll rediscuss this at the end of the presentation. So as you all know, DALK stands for deep anterior lamellar keratoplasty, which is the technique of choice, has established itself as the technique of choice for diseases in which the corneal stroma is affected, leaving behind a healthy endothelium. And that includes keratoconus, corneal scars, corneal dystrophies, and to a certain extent, infections. Now, is it important to have an intact descemet membrane when we do DALK? We'll see. I don't think it's that important or as important as it was thought to be before. There are many techniques for DALK, and as it is often the case when there are many ways to Rome, it means that no one of them is perfect. The way I categorize them in my head for simplification is that there are techniques based on dissection, which means peeling, so you can peel the stromal layers. And that's using a variety of different instruments, injecting air or injecting water inside the stroma to swell it up and facilitate the peeling, but the principle is the same. And in the other technique, it's essentially about finding a cleavage plane between the stroma and the peristematic layer, or the peristematic layer and the decimate. Among these techniques, the one that's really established itself over the years is the so-called big bubble technique, introduced by Mohammed Anwar in 2002, which is the one where there's a forceful injection of air in the deep stromal layer to separate, again, decimate or the peristematic layer. Now, if you listen to any of the developers of this previous technique, or if you read the literature on any of these previous technique, they all sound more or less like this. I don't know if you could hear the audio.
I can't hear it. Can you replay that one? That's an important part of the lecture.
That's a very important part of the lecture. Disconnect my...
They've done studies, 60% of the time it works every time. That doesn't make sense.
Could you hear that now?
Yeah.
So basically it says 60% of the time it works every time, right? So, which means that none of these techniques is essentially perfect, right? So this is just a video of a step-by-step big bubble technique done in a patient with previous RK. You can see the 6 RK cuts. So we start with the partial thickness trephination. Then we used a dissector, a blunt dissector. In this case, that's a Fogler spear commercialized by Moria, no financial interest, to make a little channel in the deep stromal layers from the trephination. And then we introduce our DALK cannula. We wiggle slowly towards the center, making sure that those folds in front of the cannula, they get smaller and smaller. Then there's a small pressure on the stroma. You can see the cornea buckling there, and the injection of hair with formation of a big bubble. Next step is the paracentesis to deflate the anterior chamber so that the aqueous would not push against our bubble when we perform the next steps. Then there's a stromal debulking step done with a crescent knife. You can see the stroma coming off in pieces here because of the previous RKs. And then the brave slash here, opening the roof of the bubble, which immediately deflates. And it's followed by the introduction of this blunt instrument, which is a double-ended spatula that I use for DALK. It's very smooth and it's useful for these delicate maneuvers, followed by the removal of the stroma in quadrants. The cannula goes in first, and then it's followed by the scissors there. We continue this in all 4 quadrants, and this cannula is particularly useful because it allows us to essentially extend the bubble all the way to the trephination margin in a very automatic way. That's the other end of the spatula, which is flatter, and it's used for the same purpose. And then careful removal of the 4 different pieces of stroma. Here you see it again. I'm pushing towards the edge of where the bubble went all the way to the trephination margin to extend the bubble to the location where I want it to be. And I pay extra care, obviously, when I'm cutting out the stroma by lifting the stroma layer. And that's the donor tissue, a little bit of vision blue to remove the endothelium decimate complex, which is removed with wax in order not to scratch the inner surface there. And then obviously the graft is positioned in place and sutured. It's washed thoroughly on the undersurface and onto the receiving cornea, and then sutured in place. In this case, I put 4 anchoring cardinal sutures, which I then remove later on, and substitute that with a 25 bite single running, which you can see right there, and that's the patient 6 months after surgery. Here we go. So this is what happens in those famous 60% of the time, but what about the remaining 40% of the time? So there are cases in which your bubble comes nicely and you see this shiny silvery appearance there, which reassures you for the rest of the surgery, but there are times in which it doesn't happen. So all you get is stromal emphysema. But this is not game over. You can still perform a manual dissection using the Mellis dissectors in this case. You go around in a circular way. Sorry. There you go. So you can go around in a circular way and obtain the same or very similar level of stromal dissection and leave behind a very clear interface. Now, as you all know, there are different kinds of bubbles that you can achieve when you do a forceful air injection in the deep stroma. There's the type 1 bubble. The floor of the type 1 bubble is formed by the decimate membrane endothelium complex and the predecimotic layer, or the Duas layer. Or there's a type 2 bubble, whose floor is essentially only made of decimate and endothelium. So it's less silvery, it's more sort of translucent, and it tends to expand from the center to the periphery. More importantly, it's extremely fragile. I've managed to pop this with everything, including drops of BSS, as you will see in the video that I show here. So here's formation of a type 2 bubble from the center to the periphery. And this is me just very sort of mildly injecting some BSS in the paracentesis, popping the bubble. So whenever I get a type 2 bubble these days, I propose a different kind of technique, which is called denial, essentially ignoring that the bubble is there and proceeding with a manual dissection over the bubble, as it's shown in the video here. Removing the stroma sort of layer by layer, and as you can see at the end, there's the bubble right there, and there's our graft just on top of it. This is another case of a type 2 bubble, which is dealt in the same way, basically ignoring the formation of the bubble and performing a manual dissection over it. There's scarring here at the bottom of this cornea, which is where you're going to see formation of the type 2 bubble that extends from the center to the extreme periphery there. The good thing about these type 2 bubbles is that you know that your initial trephination was very deep. So you can use that as a guide for your manual dissection. So we remove a little layer of stroma first, do a paracentesis to reduce the pressure a little inside the eye. And you can see now the outline of the type 2 bubble sort of crossing the center of the cornea there. And we start with our Mellis instrument, first the pointy instrument and then the semi-sharp ones to conduct a manual dissection. The way I do a manual dissection is that I usually proceed circumferentially in the periphery, almost like peeling an apple, because that allows me to get deeper and deeper as my manual dissection goes. There you go. So I go centripetally, and then at some point, I switch from this instrument to this other one, which is the one you've seen before. It's very smooth, it's very polished. And it's also a diagnostic instrument in a way, because if this goes in smoothly, it means that I'm very, very deep, right? So I complete my stromal dissection with this instrument here. This is a large diameter DALK in somebody with keratoconus, I think. There you go. Now, the one thing I would recommend, though, is that it's okay to leave the type 2 bubble in place. It will deflate on its own, but sometimes, you know, it will result in wrinkling of decimate membrane. So I'd recommend at the end of surgery to pop the type 2 bubble purposely, deflate it to avoid future wrinkling. Now, there are very many ways you can pop decimate membrane. I think I've done them all in every possible step of the surgery. And I'll show you some videos of how things could go wrong. So first of all, you can end up getting a full thickness trephination, which is undesirable. Unfortunately, Hesper Barrow trephines are not the most accurate when it comes to that. Not all is lost. You can put a few stitches in the area where you got the full thickness trephination and proceed with the manual dissection starting from the opposite side. You know that your trephination is very deep, right? And then slowly make your way towards the area of full thickness trephination and excise the stroma, or thin out the stroma on the area of trephination sort of slowly as you go, leaving behind a good surface. Sometimes your cannula goes a little too deep, in this case right in the anterior chamber, immediate sort of drop in resistance. Then what you can do is you can inject air in the stroma, get a little bit of emphysema, and perform a manual dissection over your little hole. When you get to the area, obviously air will escape. You'll have to replenish it in the anterior chamber. And again, very gingerly and very slowly dissect all the stroma and remove it with your scissors using different kinds of instrument. Here you see how delicate I am in trying to remove the tissue over the area of the hole. And that's the final results about 3 months after surgery. There's a little bit of haze here close to the center, which is essentially visually irrelevant. Again, more pops of decimate while debulking the stroma with crescent. Same principles apply. You can use your blunt dissector of choice to try to do a delicate stromal removal, leaving that area with the hole for last. That's a case of a large DALK in a patient with PMD, which you don't really want to convert to PK as much as you can, and she's done really well. Or even with the bluntest of instruments, sometimes you can still go through. Again, you know, same technique, same principles apply. Stromal dissection, leaving a patch of stroma in the area of the hole. It will result in a very small opacity, not visually significant. And this is the most disappointing of them all. When you're thinking about your next case, you're listening to music and relaxing and suturing, all of a sudden, even with a suture, you can pop your predestinate layer right there. Those ones are usually inconsequential. You just need to leave an air bubble in the anterior chamber. So what if it's not you that's causing the damage to decimate and endothelium, but it's torn to begin with? So once you become a little more comfortable with surgery, you can start tackling cases in which the decimate is torn to begin with. For example, this is a penetrating trauma with a nail 9 months after corneal gluing. There's a central scar there. Now, in these cases, obviously, big bubble DALK is not an option. So you inject air in the anterior chamber and you start your manual dissection. See how carefully I try to find the deep layer in which I want to start my trephination, because that's going to determine how easy are the next steps of my surgery. I try first with my blunt dissector. I see that the blunt dissector doesn't proceed very easily, so I move on to the semi-sharp dissectors, which are this is the middle Meles dissector, and I go obviously on either sides of the area where I know the perforation had occurred. I cut out and debulk some of the stroma to make the rest of my surgery more easy. Then at some point, I identify a layer which seems to be quite deep, and that's where I introduce my blunt dissector. See how easily it proceeds in the dissection of the stroma, and air escapes, so I know that I'm right where I need to be. So put a little more air inside the eye, cut out the stroma on top of the perforation, and sort of thin it out as much as I can, followed by an extension of my dissection with the blunt instrument now. Very, very careful over the area of the full thickness perforation until I find a plane that's satisfactory to me, and I eliminate as much stroma as I can. Here you go, and then you'll see that the final result here is, again, a very tiny, very small opacity in the interface that doesn't alter any visual recovery, like the one you see over here. Same considerations apply to the surgery that's done on somebody who had a lamellar patch graft for a perforation. Essentially, you'll see the same technique, so a manual dissection from side to side until you identify a deeper plane. It's useful to wash the cornea every once in a while and just check how transparency is to decide whether you want to continue and take another layer off. Sometimes it's difficult to stop and know when it's the right time to stop your manual dissection. But with a little bit of care, you end up getting a good interface and very good transparency also in these cases. Another chapter altogether is the chapter of hydrops. Now, in hydrops as well, there's a discontinuation of Decimet's membrane, so a big bubble dissection is impossible. That's why you have to proceed with a manual dissection, going from side to side around the area of hydrops at first, and then very gingerly over the split and decimate, filling the anterior chamber with air, checking your transparency every once in a while. And in these cases, you can do, but leaving a little bit of stroma over the area of hydrops, which will thin out significantly over time. That's the case on the GA of a 20-year-old boy with a very advanced keratoconus, bilateral hydrops, and autism. So in those cases in particular, very important to try to achieve a DALK. Same principles that you've seen before apply. So dissection on either side of the area of hydrops, leaving the most delicate part for the end. Now, there are cases of hydrops where the split is just too big or too central. In those cases, obviously, it's a bit of a judgment call, but oftentimes a PK will result in a quicker visual recovery for the patient with less postoperative complications. What about full thickness scars? Now, I think that to a certain extent, true decimate or pure decimate never scars. And that's something that, DMEX surgery has taught us. In this case, obviously, big bubble dissection is impossible, so you won't be able to see. So first of all, I make a full thickness trephination there, making my life even easier in a case like that. But then I start my manual dissection from the other side, like you've seen before, and I start taking out layer by layer. There's a lot of bleeding from the peripheral neovascularization. So one layer is out, then I go for the second layer. Under the second layer, there's still scarring. I'm starting to lose hope here, but I still continue my dissection. So that's the third layer now. Again, there's scarring under my third layer. But then at some point, I identify a deeper layer, open up the stroma, and you see this, this beautiful image, brilliant translucency there. I inject some viscoelastic to protect decimates, but that's pure decimate there. There's not a pre-decimatic layer, and I complete my stromal dissection. So this is kind of interesting. I put it out there. Just a new paper that came out is published on the BJO by the Massimo Bosin group. So in some old PKs in which you see recurrent ectasia or anterior stromal scarring, you can actually perform the DALK over a PK. Just do a 9mm trephination, then use your crescent to essentially cut towards the PK, the edge of the old PK. And then oftentimes you'll be able to identify the edge of the old PK and dissect it from decimate using blunt scissor. It's been the experience of almost every cornea surgeon. Sometimes when you redo a PK, that you do your trephination in the old PK, you take it out and that leaves decimate behind. So this technique takes advantage of that with very low endothelial cell loss. I've tried it in one case. I have not succeeded, but I will try again. So this is about the surgery. So interesting, exciting surgery. People don't do it. So we ask ourselves why DALK, although having been around for quite a while, is still extremely unpopular. These are data from the EBAA 2019 or Australian Corneal Graft Registry study. DMEC has surpassed DALK in terms of numbers. The number of DALKs are stagnant in the US, about between 1% and 2%. They don't seem to improve much, over even very long period of time. So we ask ourselves why, right? It is a difficult surgery and it requires a bit of a steep learning curve. Oftentimes it will suck up some of your time in the operating room. So prolonged surgical time at the beginning. A suboptimal execution of the surgery can result in variable visual results. The other thing is that the reimbursement in some places, like for example, British Columbia, a DALK is reimbursed by the health authority less than it is a PK, right? So it's also financially, in a way, inconvenient, right? So we've tried to sort of brainstorm and come up with an instrument that would make DALK easier. So based on our experience with DALK, we know that the orientation of the stromal lamellae is sagittal in the anterior third, and then it's coronal in the posterior third. But more importantly, the lamellae are less and less packed. In fact, when we introduce our DALK cannula and we go deeper, we almost feel a sort of drop in the resistance of the tissue. So based on this feeling that we observed during DALK surgery, we came up with this pressure-sensitive device. So the device has a pressure generator which keeps the air pressure constant within the system, and it's essentially capable of perceiving and measuring that drop in pressure. So that's the way the device looks. Again, it's experimental, not commercially available, but we've done some experiments on this where we've placed the cannula purposely at different depths within the cornea, and we've seen that when the cannula remains shallow, there's no modification in the pressure within the system. When the cannula goes lower, then there's a delta P, so there's a change in pressure, which is directly correspondent to the depth of placement of the cannula. Then what we did is that we simulated the big bubble in 4D corneas ex vivo, and we've seen that in all the cases in which the big bubble was successful, the device was able to pick up this differential in pressure, which was not detected when the big bubble was not successful. So it's capable of essentially producing a consistent signal which would correspond to a successful big bubble. More studies are on the way. Clinical trial is also in the pipeline, and we'll keep you posted. So the million-dollar question here, and I'm getting to the tick of my presentation, is that is DALK really worth the effort, right? So let's look at how DALK performs in comparison to PK in all these different aspects here. So when we examine visual acuity, we have to look into what kind of interface we produce with our surgery. So in a pre-decimedic DALK, what we're going to have is a stroma-to-stroma interface between the graft and the host. In a decimedic DALK, there's a stroma-to-decimate interface between graft and host. These are scanning electron microscopy pictures, and you can see when only decimate is left in place, how smooth it is, and potentially optically better than a pre-decimedic layer. And that's essentially what happens in the short run. So these are some early studies done on DALK, where what we've seen was that the decimedic DALK was comparable to PK in terms of either visual acuity or contrast sensitivity, but the pre-decimedic DALK fell short. Again, these are early studies with a short-term follow-up. Things change when you consider the long-term follow-up. So in the long run, even the pre-decimedic DALK will perform just as well as a decimedic DALK. And that's possibly due to thinning of the residual stroma or pre-decimedic layer that's left in place with a time-dependent improvement of visual acuity. What that means in practical terms is that not getting a big bubble and performing a well-done manual dissection would essentially land you in the exact same place. When we look at astigmatism after PK or DALK didn't seem to be particularly different in previous studies. Graft rejection, studies on graft rejection after PK, they have a very large range of percentages with consequent sort of graft failure. Same happens in DALK, so there's a large variability in the percentage of rejection. But what's interesting to notice is that that doesn't translate into graft failure or regraft as much as it does in PK. So that's a case, for example, of acute rejection treated with topical steroids intensively, which recovered full transparency within a month. Now, that's not always the case in DALK. There is DALK rejection that lands you with an opacity, but it's by all means less common than it is in PK. Endothelial cell survival, these are studies performed in different parts of the world. So after a PK, we know that there's a steady sort of decline of the endothelial cell count over time. Whereas after DALK, what happens is that there's a dip right after surgery, but then after that, it tends to remain stable over time. And that's also shown in our 10 years data. Corneal biomechanics after the 2 surgeries. Now, we unfortunately all had to deal with this kind of emergencies. Friday night special. Patient with PK bangs his eye on the bedside tables, expulsive hemorrhage, and very difficult sort of situation to rectify. These are 2 cases of DALK following airbag trauma, so a significant trauma to the face. In both cases, DALK essentially held its shape with a broken suture and the hist graft here, but with no loss of chamber. Corneal hysteresis studies have shown that the hysteresis of a DALK cornea is essentially comparable to the one of a native cornea. Sorry. Last but not least, cost in this day and age. So DALK is more expensive than PK, but these are two studies conducted in the Netherlands and in Singapore. So when quality adjusted life years are taken into account, DALK results into more qualis than PK. So if you correct the cost per qualis, it's actually even cost efficient or cost effective. So let's look at all of these previous point with a more critical point of view. So what you've seen so far is essentially based on single institution series, right? So as you've seen in the previous slides, the visual acuity and the astigmatism are comparable to PK. DALK probably has less rejection or less eventful rejection, lower endothelial cell loss, better postoperative complications profile. But how important are these studies? These come from institutions where there's usually somebody who's very experienced in this type of surgery. So those studies don't necessarily apply to the reality of everybody when it comes to day-to-day cornea, right? So let's take a look into higher levels of evidence. For example, actually before that, so I've been to a lot of DALK talks. I've given a lot of DALK talks myself, and those talks are usually given by people who are very experienced in this kind of surgery. So in general, those type of experts, they tend to, let's say, overestimate the applicability of a certain surgery. So that's why you will see titles such as DALK no limits, big bubble no trouble, cliffhanger DALK, never compared to PK. You will hear experts saying, I don't remember the last time I had to do a PK, or doing a PK in this case is unethical. So all of these talks, after a while, to me, this.
Anything you can do, I can do better. I can do anything better than you.
Oh, you can.
Yes, I can.
So, we're better than this. Let's not surrender to surgeons' vanity or
Anything you
or for that extent to what I would call a surgeon cognitive bias. So surgeons, oftentimes they think that the newest surgery, like laser cataract surgery, or the most complicated surgery is, by default, the best one for a patient. But, not always that is the case. So as I was saying before, let's look into this higher level of evidence on DALK. So when we look at meta-analysis or systematic reviews, there's a few available there. Now, meta-analysis oftentimes are a bit of a mixed bag. They include studies that come from different geographic areas, not always comparable to one another. It's to be fair, conducting an RCT on a newer surgical technique is a difficult task. So unfortunately, all of these previous meta-analysis, they might agree on some elements, for example, less rejection or a better endothelial cell count, but they present us with a variety of different findings that not necessarily help us in understanding, if DALK is really comparable to PK or better than PK. So let's move on to an even higher level of evidence when it comes to transplant, by some regarded as the best evidence for examining outcomes of any sort of transplants, which are registry studies. And I'll talk to you about 3 different registry studies. The first one being the Australian Corneal Graft Registry study. So when it comes to DALK, they've analyzed DALK versus PK in keratoconus, as you see in the diagrams up there, in the period that goes from 1996 to 2013. DALK fell very short of the expectations in this registry, with a survival that was by far lower than PK and a worse visual acuity. To the point that the authors of this study, in their paper published on ophthalmology, conclude, and I quote, The history of ophthalmic surgeries includes many procedures that were introduced with fanfare only to fade without a trace. That's a bit of a slap in the face. It's a bold statement there. Now, turns out that these studies had several potential pitfalls. For example, they started including DALKs from 1996 in Australia. And before 2006, very, very few of these procedures were performed there. So DALKs had a longer follow-up, PKs had a longer follow-up than DALKs. They did not, as it's done usually for Kaplan-Meier curves, they did not censor their data rightly. They did not show a number at risk table. So many criticisms have been raised against what this study presented. And in 2018, they actually modified a little bit their findings. So still the survival of DALK was inferior to PK, but this time they did present the number at risk table over time. And they saw, when you look at the probability of graft survival, you can see that they tend to come closer, much more in their new presentation of data than it did before. One of the things that the authors in Australia were saying in their defense is that, oh, UK is just the same as us. So in the United Kingdom, the Ocular Tissues Advisory Group, or OTAG, published a series of very interesting studies on transplants. And what they observed in the beginning was indeed similar to Australia. So a lower survival rate for DALK compared to PK, so DALK is the broken line over here, for keratoconus over 3 years. But they did something different though. So they have eliminated all the failures of DALK occurring in the first 90 days, which are the ones that more likely would happen when suboptimal surgery was performed. And by removing those first failures in the first 90 days, then the 3-year survival equalizes, right? So what they did is they looked into the effect of experience when it comes to DALK performance, but this time they were not able to show any effect of experience on graft survival, which was a little bit puzzling and has not been explained by the authors yet. One of the possibilities is that the numbers are too low to really show an effect of experience, which has been shown, for example, in endothelial keratoplasty, but it remains up for debates. Last registry study that I will show is the study in Singapore. Now, in Singapore, the first study of 2015, Donald Stan, American Ophthalmological Society thesis, DALK blows PK out of the water. So definitely superior. They've published a follow-up study in 2020, again, better survival rate for PK. And even more importantly, for all the indications in which the endothelium was healthy, essentially the survival of DALK did better than PK. So they compared about 300 versus 300 cases over a 10-year time point. Now, Singapore is a singular place in the sense that there's only 8 to 10 cornea specialists in Singapore. Most of these DALK surgeries performed by a very limited group of them. So for all intents and purposes, this registry study is more of a single center study than a registry study. So that's why maybe the results are so overwhelmingly positive. I just want to conclude by talking a little bit about the therapeutic DALK. It's an interesting and enticing concept, right? To only perform lamellar surgery for therapeutic purposes in infections. The pros would be less rejection, less endothelial cell loss, no potential intraocular seeding, but at the same time, it can be very challenging technically. And there's the risk of leaving behind significant residual infectious disease. So there's a group in Italy who's been the biggest proposer of this approach. But if you look at their studies, they recommended a very early surgical approach, 10 to 15 days in acanthamoeba, 3 days at some point in fungal keratitis. Now, we all know that these infections don't usually respond in 2 weeks or 3 days for that matter, right? So I'm not quite sure that the medical treatment would not have done really better than surgery in some of these cases presented. And a very known expert in infectious diseases, Bhupesh Bagga from LV Prasad, actually showed his series on therapeutic DALK on acanthamoeba, And the results are not very comforting. 20% recurrence, 60% failure, an eradication rate of the infection, which is only about 70 to 80%. So that's lower than what's expected from a therapeutic keratoplasty. So let's go back to our initial cases to see if somehow, you know, we've changed our mind or if we're set on what our thoughts were before. Now, this is up for discussion, but in a 26-year-old male with keratoconus and contact lens intolerance who has, you know, access to a hospital sort of nearby him, I think in this case we have to give it our best and try to strive to obtain a DALK. Also because, and this is based on mathematical modeling, DALK is likely to outlive PK in somebody with a long life expectation. In a 70-year-old patient, that's probably not as important. In particular, if, for example, we end up getting a descemet perforation during surgery, so the patient may need continuing care, may need a rebubble, she may be far from our hospital. So in this case, is it essential to obtain a DALK, and would DALK be absolutely, you know, superior to a PK? I would say no. So in conclusion, when we compare DALK and PK, we actually saw similar refractive outcomes and visual outcomes. Survival is at least similar in what's been shown so far. Maybe time will tell and will help us understanding if DALK can live more than PK when we look into multiple decades. But definitely DALK offers a better complication rate for postoperative complications such as resistance to trauma or rejection. So, So is DALK worth the effort? I would say yes. For anybody who performs this technique or is familiarizing with DALK, you have to be able to master different ways of taking the result home. Most importantly, don't give up. Don't stop believing. As you've seen, a perforation in descemet doesn't necessarily mean it's game over. Patients can still undergo DALK even if the descemet was torn because of the pathology, you know, they come to see you for. And we should continue our personal efforts and, you know, efforts towards others to teach this surgery and educate. And these are pictures from our DALK course at the American Academy that's been going on for, I would say, probably close to 15 years. I've been involved with it for half of its life. It's a nice bunch of people, very educational and very useful for anybody who wants to take on this surgery. Conversely, should DALK be performed at all costs? Definitely not, right? PK is not the enemy. He's alive and well, will continue to serve ourselves and our patients very well, and doesn't need to be, blamed for all, postoperative complications based on what we've seen. At the end of the day, there's no better surgery, but there's only the surgery that serves the patient best, taking, you know, many elements into account that are specific and peculiar to that patient. So with this, I conclude. I thank you very much for your attention. That's my email. I'm working on a thematic channel for DALK on YouTube, which at some point will come up when I find some time. But that's about it, and I'll be happy to take any questions.
Awesome. Thank you so much, Alfonso, for this nice overview. Yeah, for sure, that'd be great. Let us know about that YouTube channel that will have these DALK video clips in it. That'll be really useful. So there's a question that came up in the Q&A section, and those in the audience can feel free to submit some questions. So we've noticed, you know, over the last decade or so with cross-linking around that, we've done thousands of cross-linking cases for ectatic patients. Do you have any comments on how, in keratoconus, how cross-linking has affected the need for doing DALK, the numbers of DALKs being performed?
Yeah, so we run a little study here in BC, which was done in conjunction with Ontario, right? Which we looked into the requirement for transplantation following corneal cross-linking for keratoconus. So what we observed is that the number of transplants done for keratoconus has essentially remained constant over time. The percentage of transplant has reduced, but that's mostly because of the increase of the massive increase of the number of endothelial keratoplasties that are performed at this latitude. So we're not quite sure that cross-linking has, manifested an effect yet on the numbers of patients that have to undergo keratoplasty. These kind of studies are have a lot of confounders, because migration, use of contact lenses, there's a lot of other elements that comes to place. So I know that other groups have looked into this, and so far they haven't shown an effect yet. It might also be that people get cross-linking at a certain stage in their life, and the ones that get transplants done are usually in a different stage later in life, so it might not have had this effect yet.
Okay, thank you. Yeah, I would agree with that. I think anecdotally for myself, I find that we're doing fewer DALKs, but we're being more, for keratoconus, but we're being a bit more aggressive in our DALKs for other anterior corneal pathology, patients with high drop, for example, things like that. So, but I say overall for ectasia, perhaps a little bit less. Another question I had is, what's the name of that instrument, that paddle or spatulated instrument that you're using?
Yeah, it's called Fontana, from the name of the person that I developed that with. It's the chairman of the Department of Ophthalmology in the place where I was in Italy.
Yeah,
double-ended spatula, and it's sold by Moria. I think it's similar to the DALK knuckle that Donald Tan made. They're this sort of like extremely polished, smooth dissectors, which you can use when you're very deep in the dissection. I think they're very useful for surgery.
Yeah, so we have the knuckle, but this is perhaps something I should look at as well. So now, when you're talking to in your DALK courses, that's probably a question that comes up quite often is, when you're planning a DALK, and especially in surgeons who are kind of early in the learning curve, what kind of tissue should they be ordering from the eye bank? And then for more experienced users such as yourself, what kind of tissue do you order? PKP quality or DALK quality?
Yeah, that's an interesting question. So we're lucky in BC because whenever we perform a DALK, we get two tissues. We get a DALK quality tissue and a PK quality tissue. Now, in some instances, the eye bank would call me and say, look, unfortunately, we have no PK tissue for tomorrow. Are you okay proceeding with DALK tissue? And oftentimes I'd say yes. In general, I mean, the circumstances can vary according to the local eye bank policies, but having a PK tissue in hand when you're performing DALK is definitely, I think, it gives you that safety net from, many points of view, medical, legal included, right? That I think should always be there. Okay.
And then also for surgeons who are perhaps early in their learning curve, how much time OR-wise would you suggest dedicating to it? And then as you get more experience, how much time are you slotting for your DALK cases?
Yeah, so I would say that in the hands of an experienced surgeon, a DALK, whether it's a big bubble or manual DALK, usually takes around an hour and 15 minutes of allotted time. When fellows are performing DALK, I usually tend to, or when I know I'm going to have a fellow in the OR, tend to budget at least for an hour and a half, or even longer than that, by sort of booking some shorter cases around it, right? But I think an hour and a half should be budgeted.
Okay. And is there anything that's different in your post-op follow-up of DALK patients compared to PK patients in terms of antibiotic use, steroid use, suture removal?
I tend to wean them off the steroids a little earlier. I mean, depending on the type of suturing that's used, for example, in a mixed running interrupted, I will be more aggressive in removing the interrupted sutures early on in DALK, because I know that the wound's not going to gape anyways, right? And so I would take advantage of the larger effect on astigmatism that I can get by removing sutures early on. One of the things that I like to do in DALKs is whenever I know that the patient is going to be able to come see me again, and it's not going to go away to remote areas of British Columbia, I'd like to obviously, if there's no vascularization or other contraindications, put a single running. That's personal preference. In my hands and DALK patients, is the suture that gives me the best astigmatic correction. I can adjust it at the slit lamp. So, but those sutures, they do break, they do cheese wire. So if somebody is then going to go and never see me again, that's not the best choice.
And how about for steroids?
And for steroids, I would say identical to PK in the beginning, with a bit of a quicker tapering than the 6 months I would do for PK. In DALKs, I would probably bring them to the 1 drop a day at 3-4 months.
And by 3-4 months, and then do you maintain them on once a day for a while, or what do you do with?
I mean, it depends on their initial disease, right? So the keratoconus patients, if they're young and phakic, I'll stop the steroids at a year, right? Or maybe have them on a surface steroid once a week or a couple of times a week, something that I know is not going to have an effect on their lens. The other ones, I tend to be more conservative, and I tend to keep patients on steroids for life. Even if it's every other day or something like that, if I'm not particularly concerned about their lens status. I think the evidence is there to show that a low dose of steroid in the very long run prolongs the life of transplants. So the same would apply to DALK.
Okay. And how about for patients who are, say, ectatic or have anterior stromal scarring, and your comments about debulking the cornea before doing the big bubble injection versus just going straight ahead without the debulking step?
Yeah, so I mean, there are obviously cases in which the ectasia, the thinning at the apex of the ectasia is such that debulking would not be really possible, right? Because you'd be right on the bubble over there. So I would still do a peripheral debulking before I slash the bubble if I can, right? Or in some cases, no debulking at all.
Okay. And so if Sonia was here, what would she be countering your arguments with?
What we intended to do at the beginning was that one was going to be the pro DALK, and the other one was going to show, the pro PK side, so the non-inferiority in a way, right? So.
All right. Well, Alfonso, thank you so much. I know I really am appreciative of your time, especially given what's going on. Hope all is well with your son. Thank you so much for joining us for this. I do appreciate it. And of course, as I may have mentioned to you before, this is a recorded session. So we'll have the, with your permission, we'll have this available on our YouTube channel, and PCC YouTube channel. Along with the other lectures I've been given over the course of this past year. So if that's okay with you, that'd be great. And then people can, a lot of people actually end up watching or listening to the talk afterwards. But thank you so much, and have a great night.
Absolutely, my pleasure indeed. Thank you very much for inviting me and for listening to my talk, and looking forward to the next PCC Rounds.
Sure, and say please pass on regards to Sonia.
Thank you. Thanks a lot.
Okay, bye-bye.